So, yeah, I was going to share some reflections on the movement to transform primary care and develop and implement new models. And I think, as Mark was saying, you always have to be a little careful about cross-national comparisons and lessons, because the healthcare systems are so rooted in the cultures and the traditions of respective countries. And there are some things that are just, hard to really understand about some of our different cultures. I would suspect many of you right now are wondering, what the heck is going on with this Donald Trump stuff in the United States, which seems kind of inexplicable to you, right? It is. So you probably find that hard to comprehend. I must say, for me, it's this Australian thing about rugby, right? Which it seems like this is a real passion of people in Australia. It was Terry and I were just and Jen at a meeting up in Brisbane, and there were a number of presentations that had some New Zealand folks presenting, as well as Australians, and you could sense among the Australians, it was sort of hard when they were listening to New Zealanders, even talking about great reforms in New Zealand, that they have this seething resentment about the All Blacks. Is that right? Yeah, so I could see this. And I know there's a story that's told in the States. Now, I don't know if it's true or not, but of the passion for rugby here, that there was this couple, William and Doris, who were fanatical devotees of your team. It's the Roosters here in Sydney. Is that the rugby team? One of the teams. There's one of the rugby teams here, and they, for decades, they went to every single one of the rugby games. And finally, one day came, and William showed up, and Doris didn't come to the game. And the people at seats next to him said, "Oh, William, where's Doris? She's never missed a game." And William said, "Well, I have some sad news. Doris died this week." And the people next said, "Oh, I'm very sorry to hear that. That's really tragic." And the game went on a little bit, and then after a while they leaned over and said, "Well, William, but we're wondering, you didn't have a family member or friend who could come with you today instead of Doris?" And he said, "No, unfortunately, no. They're all at Doris's funeral today." So I don't know. Is that I don't know, Nick. Is that a true story, or is that just me? I don't know. That's so. All right, but the passion, I hope that passion can be transferred to innovations in primary care and reform of primary care. So that's what I'm going to talk about today, is starting off a little bit what's going on in the United States and trying to understand the United States context in primary care, the reforms, sort of with the Affordable Care Act, Obamacare, a lot of the momentum to really pay more attention to primary care and really re-engineer the model of primary care, and what's that about. And then thinking more broadly beyond just this patient-centered medical home neighborhood, but really about primary care integrated in the broader health sector as well as the social service sector. So that's what I'm going to try to cover, and then look forward to your comments and thoughts. So primary care traditionally in the United States was really not valued. So I've been a family doctor for 30 plus years in the United States. I must say, it was, not celebrated. It was about high-tech, specialty, biomedically oriented care. Primary care was really in the shadows of this gleaming hospital-based specialty sector, undersupported. And that has started to change in the last decade, that there's been greater recognition of the vital importance of primary care for seating at what we call the triple aim. Have you heard about the triple aim? This is sort of our guiding vision in the United States now, which is better care, better health of the population at a more affordable cost. And also now what we're talking about, value-based care, which is, again, usually that's put in the context of moving from volume-based care, which is just how many visits, how many hospital sessions can you have, towards how do we actually make sure we're investing in healthcare that is good value in terms of the overall health of the population. So as part of that, there's been a recognition of the importance of primary care. And this really came to a head during the debate over healthcare reform. I had the fortunate position of being an advisor on the health policy group when Barack Obama was running for president in the United States in 2008. And we really had tried to say, if you're going to reform the financing of healthcare, try to get more people insured, and we have a very embarrassing lack of universal coverage in the United States, but you have to then think, what is the delivery system and what's the infrastructure to provide care, particularly as you're thinking about expanding coverage, and how important it is for primary care. So this was a comment that the president gave at a town hall meeting, and just to be clear, this wasn't like a prepared speech before, the equivalent of the Royal College of General Practice. This was just a spontaneous comment in response to a question that was asked by a consumer at one of these town hall forums, and I'll let you read it yourself. But to us, this was a watershed moment in the United States, to have the President of the United States actually say the two words together, family doctor. I don't think I'd ever heard a president in my country actually talk about family medicine, primary care in this way. So that's very exciting. And it wasn't just the political leadership. This was a hearing. There were a lot of legislative hearings leading up to the passage of the Affordable Care Act. And this is, a vice president from IBM, a big Fortune 500 global company. And he was testifying before this committee from the point of view of large employers and business and saying, what is your priority for healthcare reform? And it was remarkable to have this, leader of the business community saying, actually, our number one priority is getting better primary care for our employees. And a congressperson said, well, what's the second issue? Enough of all this patient-centered medical home stuff. What else is your priority? And he replied, basically, there is no other priority for IBM. If we don't have good primary care, it's hard to see the rest of the system working well for our employees and other people in the nation. And IBM became very influential in really building a broad coalition among the business community, the health professional community, the political community, with Paul Grundy, who maybe a number of you know as the figurehead of that movement. There was a lot of research then that was starting to come out about, really confirming how important primary care is to the triple aim. This is a report I testified before one of our Senate committees, again, leading up to the Affordable Care Act. This is a government commission that reviews a lot of the evidence on requests from our Congress, the Government Accountability Office, and this was their conclusion, which was basically saying one of the problems in the United States is we have an upside-down pyramid. What you'd want, which is more what the system looks like in Australia, which is a sound foundation of primary care, a pyramid on that really secure base, and then you move your way up towards specialty and tertiary care. And that in the United States, what we've seemed to do is built an upside-down pyramid. Here's more evidence that was cited in the report. This is just comparing all the states in the United States, and what they look at is the number of primary care physicians per capita in those states, and then they look at reports that come in on all of our Medicare beneficiaries. So our Medicare program is largely an insurance program run by the federal government for seniors. There's a few other populations like folks with kidney failure on it, but it's limited to just largely older people. And they look at the quality of care based on Medicare, collects information on flu shots for seniors and appropriate medications after a heart attack. And you see states that have a more primary care orientation had much better quality, and then the opposite was true for cost. States that had a more of a primary care oriented workforce spent less per Medicare beneficiary per year than those that had a more specially oriented system. So there was a lot of evidence accumulating about this. And President Obama's actually first choice to head our health department at the federal level was Tom Daschle. He had been a senator. He wasn't confirmed, had a little problem with some chauffeur episodes that weren't reported to our tax agency. But he said a very telling thing, which was this indictment of the upside-down pyramid in the United States, that we seem to start with our funding priorities are what new technology can we buy, what new hospitals can we build, and whatever is left over are the scraps that go. Same here. So there's that tension. Yeah, all right. So maybe you're not a pyramid, maybe you're just a rectangle then in Australia. Rather, or I don't know if you're an upside-down pyramid, but the same tension. So and we all know that this is not a very stable healthcare system. Now, as the evidence was coming in about the importance of primary care, as the political momentum between government, between employers was saying we really need to strengthen primary care, this very stark reality was facing us, which was we were having a declining workforce in primary care. That fewer and fewer of our own medical students were pursuing careers in family medicine. We also have some internal medicine physicians who do general adult primary care, pediatricians. And these are just some data from this is looking, we have what you would call registrar positions, correct? Which would be family general practice training. These are basically our equivalent. These are family physician registrar positions. This is a number offered in the United States every year, and this is a number of graduates of our own U.S. medical schools going into those positions. So you can see there was this big decline. And so a huge fear about where's the workforce coming from. Now, some of these positions we fill with an international medical school graduates, including maybe some from Australia. But it was still a real worry about a declining workforce at a time of great need. And we said, well, what's going on? You know, why are people not following along with Dr. DeVoe and me and wanting to become family physicians? It's really a kind of dispiriting thing, because I love my career. I love being a family doctor, and to see these students who are increasingly going to subspecialties. Well, this was part of the issue. Our medical education is not publicly subsidized by and large at the medical student level. People come out of medical school with $100,000 to $200,000 of debt from having to pay for their own education. And what this shows is the relative income of a general practitioner to a specialist in the United States. So you could see it's about, it dropped about half the earnings of a GP compared to what you could make as a specialist. And what you can see is the number, this is a percent of graduating medical students saying they want to be a family doctor, and it tracks very closely along with the relative earnings you can make. I would say you don't get to medical school by not being able to add, and people have basic rudimentary math skills. So there's this market, a labor market in the United States, where we have allowed specialty earnings to so get ahead of primary care physician earnings. And the same, it's not just true in physicians. We're seeing the same in nursing or nurse practitioners or physician assistants, a lot of pull into specialty careers. And then this is the other thing that we realized was discouraging people to go into general practice, was how hard a job it is in the United States environment to make it work in primary care. How many of you are do clinical practice in the room? All right, in primary care, many of you. I just saw some data for Australia at this meeting we were at, where the burnout rates seem to be lower, but the burnout rates among physicians in the United States are really troubling. This is a standard scale, a survey that's done of workers in the United States, and there's a certain score you get, and that indicates high burnout, meaning like I feel exhausted before I even start work in the morning. At the end of the day, I just feel like I just want to kind of collapse and have my glass of good Australian Syrah or something like that. So this is it. So the physicians with the highest burnout rating, family medicine was right up there. Our general internal medicine was up there as well, very high. This line is the average employed person in the United States in terms of the burnout. So this is very disturbing. Just saying, is primary care a doable job? And why does it feel like it's not just a doable job? So it doesn't pay as well, but then it's harder when you go to work and you just feel the system isn't working. And that was the new math of the 15-minute visit. So there was a study done in the United States of, take a typical general practitioner, the number of patients in his or her practice. Let's look at all the preventive care services that our evidence-based commission would say patients would need. And when they did that, these are things like cervical cancer screening and mammograms and depression screening. They figured that would take about 7.5 hours a day per general practitioner just to do all the preventive care. They did the same study and said, well, what about all the chronic care, the diabetes care, the care for obstructive lung disease, for depression? That would take 10.5 hours a day. This for about 2,000 patients. So that's 18 hours a day just to do the preventive and chronic care. Now, I don't know about you. I mean, there is some good news in here, right? That's 18 hours. That means there's 6 hours left in the day for a general practitioner to actually tend to people's symptoms and why they come to the office if you're willing to work 24 hours a day. So this is the problem. There's so much more we can do in primary care, right? I mean, there's actually all this evidence-based work we can do to keep people healthier, address preventive needs, work on chronic care needs. So it's totally shifted from episode-based, I have a stomach ache, I have a sprained ankle, towards chronic care management, aging populations, psychosocial integration of care. And it just feels overwhelming to try to do that in the old style. So we've concluded that, the 20th century model of primary care just isn't going to work for the demands of 21st century primary care. And I think that's true in Australia as well as the United States. You're not there yet, I think, with the burnout, but I think the model needs to change. So this is, I don't know, people get this. I know this is This is the proverbial fork in the road, okay? So that's what that's about. So we have a fork in the road where you can keep doing the old model of general practice, or you can say it's time to embrace innovation and different ways of doing things to really meet the needs of the people we're serving. And that's this whole primary care transformation movement. In the United States, it's come under the name Patient-Centered Medical Home. Some people just call it advanced primary care. Our group calls it high-performing primary care. Other people just call it damn good primary care. But it's really about how do we deliver excellent primary care. So what are the features of this? So this came out, there was a whole rallying of our different specialty organizations in primary care around these joint principles of the patient-centered medical home. And what I want to try to do is just deconstruct this concept because it's a bit of jargon in some ways. And you're saying, well, what is this? I mean, how many people say, yeah, what in the heck is that patient-centered medical home? Has anybody heard that, or people could get up here and tell us? All right, so it's like one of those things, it sounds good, and then somebody you go to a cocktail party and says, oh, you went to a talk on the patient-centered medical home. Can you tell them something about primary care and homes and medical homes and nursing homes, funeral homes? I don't know, something about that. All right, so here's what it is. So a group, Shortell and Rittenhouse, or a couple of authors said, the first thing to understand, it's about primary care. It's fundamentally not about saying we're like it's a whole new thinking about what primary care is. It's still, primary care comes down to giving first contact accessible care, comprehensive care for the majority of needs patients have, continuity, relationships over time, and coordination of care, the integration. That's all true. That's the eternal pillars of primary care. What the patient-centered medical home is about is that it needs to be more patient-centered. And I think Nick and Mark were saying we have some consumer folks here. So this was about, wait a minute, maybe actually we need to be much more focused on what is it really that patients need rather than how do we just do things from a doctor-centric point of view. So that's a lot of it, is how do we tune in better to the patient, to the consumer, and really build a system that works for them rather than just they have to fit into our prerogatives. Second is, it's going to require, therefore, a different way of delivering care. To get to continuity, to get to comprehensive care, we're going to have to think, how do we design the practice to deliver them, not that we're changing the fundamental principles. And the final thing, and this is something that I think you're contending with Australia, you then have to change the payment model. Because it's very hard to do this on pure fee-for-service, where all you're getting paid for is that patient showing up, sitting down in front of you for the 10, 15-minute visit. So what are the key elements of the new model? So here's my best attempt to just distill it down as simply as possible. That is a photo of a general practitioner from the United States from the late 40s, early 50s. My guess, does that look like kind of the image of a classic general practitioner in Australia, maybe somewhere in rural Australia? And that has been the iconic view of the family doctor. You have your bag, whatever the problem is, I'm going to deal with that. I have my medicines in the bag. I'm going to go splint the farmer who just got kicked by the horse. I'm going to be able to do this care, deliver a baby, go take care of somebody in the hospital. But this idea that I am going to be the generalist who does it all largely myself. And what we're realizing is that's the recipe for burnout. If you have 18 hours a day of preventive chronic care, there's no way you as an individual solo general practitioner are going to be able to do that. So now we're talking about it's going to take a team. It is going to take a team, and you have to think about a general practitioner working with nurses, pharmacists, health workers, health educators. I went to a wonderful practice in Brisbane by Dr. Ian Williams, and it was great. He has a nurse educator, a diabetic educator. So again, that's a lot of time educating people about their diet, their lifestyle, insulin issues. That's if you just don't have time to do all of that. So you need somebody who can partner with you as a general practitioner. Mental health folks. People who can track, are people overdue for their mammograms and things like that, their pap tests, that you have a whole team on working that so that the physician can focus on physician level work and the team can take on a lot of those tasks that really don't require advanced training to do. So that's a new model. The second part of it, it's not just really patient-centered in truth. In some ways, a patient-centered medical home may be a misnomer because it is thinking much more about patients. So again, just like access, and that was fascinating with Dr. Williams, is again, what's a typical GP office hours? 8 to 5, something like that, right? What time do working people prefer to go to the doctor? After work, before work, you have kids in school. It's basic things like, well, we maybe need to think about our office hours. Are we open for evening visits? Are we open earlier in the morning? Are we open on weekends? That's the patient-centered. It's not just, here's our appointments, take time off work and give up half your day to do. It's how do we just even think about our appointment system? Do you have same-day appointments? Can a patient pretty much call up and say, yes, if you're part of our practice, we'll see you within 24 hours. So that's the patient-centered. But we're realizing it's not just patient-centered, it's population-centered. That our job as a general practitioner and a team working in general practice is actually to be accountable for all the patients we're responsible for, not just one patient at a time, which means actually knowing who are the patients you're accountable for. Because what you want to do is reach out to that diabetic patient who hasn't been in for a year or more, who has poorly controlled diabetes. It's no longer enough to just say, when they show up, we'll deal with it. You have to do proactive outreach and track them down and try to understand what's going on. And the issue may actually be housing instability, or there's depression going on, and that's why they're not coming in. But you need to be proactive and be responsible for that whole population of patients. Same with your preventive care. It's not just enough to say, have we immunized the people who showed up? What about the people who haven't been in? Are we calling them up, bringing them in? So it's team-based care, patient-centered, and moreover, population-centered. That's fundamentally the patient-centered medical home. Does that make sense to you all as a concept? Built on the eternal pillars of continuity, comprehensiveness, first contact, and coordination. Okay. So now in the United States, we have of course, in the United States, we like to measure everything and grade everything. So there are these bodies, and you can get your patient-centered medical home plaque that you put on your wall if you do all these kind of elements there. This is a National Commission for Quality Assurance. We have a Center for Excellence in Primary Care at the University of California, San Francisco. We went out and tried to actually say, let's not just do the checklist. That's a little superficial in our view. Let's actually go out and find the practices like Dr. Williams in Brisbane, our versions of that in the United States. We're a practice that seemed to be really working well for patients and make people happy to go to work each day, the people that work there. And we went all over the U.S. to visit some high-performing practices, and we came up with our own model of kind of our patient-centered medical home model, which we call the 10 building blocks of high-performing primary care. You can get all these things that I'm presenting at our website, which is just cepc.ucsf.edu, Center for Excellence in Primary Care at University of California, San Francisco.edu, so cepc.ucsf.edu. So this is our model of high-performing primary care. It starts with engaged leadership. You need to ask, and I know we have somebody from the Royal College here, that, are GPs committed to leading a different model of care? Because it doesn't get started unless there's leadership at the ground level. You can't do this from purely a primary health network. You can't do this from government. You have to have leadership on the ground in practices saying we're willing to go on this journey to change the way we do things. Again, that's what impressed me so much with Dr. Williams up in Brisbane, is leadership. You need the data. The third block is empanelment, which I think is a big issue right now in Australia. You actually do need to know who are the patients you're responsible for. Much easier in a New Zealand system where people are formally registered with some capitation payment that goes to that. Harder in a fee-for-service system, but this is a big issue. There's places like Canada have done this under voluntary enrollment. We in the United States are doing it in ways where at least we try to have a sense of who are the patients we're caring for, but you really need to know them. Team-based care, as I said, is the other foundational building block. And then we get up into really engaging with patients in partnership, managing population health, as I said, continuity of care, prompt access to care, comprehensiveness, care coordination, I'll talk more about. And the template of the future is the final pinnacle block, which is beginning to say, actually, do we need to do all this as individual face-to-face visits? Should we change the template for a GP's practice in a day? And again, for the patients in the room, do you really need to go back in to discuss that latest diabetes test result and adjust your medications, or could you have a virtual visit if you're on a online communication tool that I could schedule a time to do a video visit or a phone follow-up, or we could just email and say, your result of your glycosylated hemoglobin is still high, I want you to increase your dose of metformin. Does that really need somebody to come in to do that, or could you do that through virtual visits? Right now, if you're a GP, you wouldn't get paid for any of that, right? So you need to change the model. That's our model. Once you change payment, then you can say we could do a lot of this, doesn't require person-to-person visits, or it could be a visit not with a GP, but with the diabetic educator or the mental health professional in the practice that may not be billable under the current models. Okay. And then the final thing we've gotten to is say, we now no longer just say it's a triple aim, it's a quadruple aim. The fourth A being joy in practice. that it's hard to say you're going to create high-performing primary care patient-centered medical homes and leave patients with a really good experience working with that practice when you have demoralized, burnt out, cynical people working in that practice. Would those, again, would patients agree with that? You'd like to get care from happy people, not burnt out, cynical complainers? I think patients have a stake in this. I actually think this is really important to the public to say we want a system where the people we're seeing feel good about going to work each day. So we have actually made this a priority, that we're not going to be successful in this transformation journey unless we're not only tracking patient experiences, but what about the experiences of people in the workplace? And so payment reform. So as I'm suggesting, traditional fee-for-service payment does not provide the engine to really allow you to move as far along as you did. I mean, I was amazed with Dr. Williams that he's gotten this far under fee-for-service. I mean, I'm not sure how he's managing to pay all the staff he has in the practice under fee-for-service. In the United States, what we're starting to move to is, even if you have a chassis of fee-for-service, to do what's called blended payment models. So this is where if a patient registers with you, or you have some, again, on a voluntary basis, you will then get an extra per patient per month payment, a mini capitation for those patients that are enrolled in your practice. And that's supposed to allow you then to hire that additional team-based staff that's outside a fee-for-service vehicle, that you would have a stable monthly amount of income coming in that's not linked to just visits, that you can use to expand staff, do creative things. The next stage is just to go to full capitation. And my understanding is New Zealand's more on that model of a capitated model. Certainly the National Health Service in Britain has been on this model. The Danish system has been on a model. It's just outright capitation, which really then forces patients to formally register with a practice and then say that's the only practice they can see unless they want to re-register with another practice. You can't just say, tomorrow I want to see Dr. Zwar, and then, next week I wasn't that, as brilliant as Dr. Zwar was. No hit Nick, but or maybe it's just convenient. I want to go down and see Dr. Harris at a totally different practice the next week. That doesn't happen under capitation. You really have to stay with that medical home. And then if you say, it's not working out for me, you'd have to change to a new home. But then you're kind of really, it's really to cement the sense of a compact between the patient and the practice in a tighter way. Another way people can help fuel some of the patient-centered medical home transformation is by just outrightly paying for some of those additional services. And that's another thing that could be thought about in the Australian context, and whether this is through primary health networks, but are there just funds flow outside of the Medicare fee-for-service system that could pay for extra staff with some accountability for what those staff are going to be doing, and more just a kind of outright granting. And P4P, which is called pay for performance, is then you have a bit of that, I think, with at least kind of your diabetes registries and things like that, some actual paying for quality or certain services delivered. Okay, all right, it sounds good. So that's nice, 10 building blocks. Are you all convinced? That all sounds, you're ready to sign up for the 10 building blocks. The question is, does it actually work? Are we getting anywhere towards better functioning primary care if we do that 10 building block type model? So there has been a fair amount of research and just kind of less formal evaluation studies going on to try to look at practices that are moving ahead on this transform model of primary care. Are they actually doing better in the things we care about? This is an annual report that I think is worth many of you knowing about, and you can find it online. It's free. It's a group called the Patient-Centered Primary Care Collaborative, pcpcc.com. They put an annual report that reviews, again, it's in the American context, all the latest evidence that's come out. Again, some of it is from health insurance plans, some from medical groups, some of it is from actual studies that are more formal research. But it tries to synthesize this. And the results look pretty good. Now, in the United States, what do you think is the single most, of those triple aim? Better kind of experience of care, better patient population health outcomes, and more affordable care. Which is the one do you think most of the policymakers are fixated on in the United States? Money. You'd like it to be care, right? But it actually, it's funny, we talk about the triple aim, but it seems like one aim gets a bit more prioritized by at least the policymakers. So it's been, so a lot of we've had to demonstrate is this investment, because this requires more money. This is a more expensive model of primary care than that solo GP if you want that bundle of services to be delivered. it takes money. The question is investment in primary care going to actually have a return on investment by reductions in hospital costs for out-of-control chronic care, in less patients going to the emergency department because they couldn't get an appointment in a timely fashion, or all the patients where what they really have is depression and what it's presenting with is stomach aches and chest pains, and they're getting endless tests and images, and what they really need is somebody to take the time to sit with them and work through their social issues. So again, the data are looking pretty good. Again, this is saying of the 23 studies reviewed in this report, 21 found reductions on cost measures, 23 found reports lower on things like hospital care, emergency department care, and I think that's a priority in the Australian context, yes, is to try to reduce expensive, unnecessary. We're not talking about, no, you have a heart attack, you need to be in the hospital. We're talking about your asthma is out of control, and it shouldn't be out of control. If you had really good team-based care that was working you and empowering you to take better control of your asthma, then that's a hospitalization we should be able to avoid. So those are the costs we want to take out that are wasteful costs, as opposed to value costs. Here's one study that I'll mention in a little more detail, and then I'll close, is Group Health Cooperative is a large, integrated, fairly progressive system. So this is, again, a U.S. Type of integrated care, more of an HMO model care, where they have the hospital, the physicians working together. But they went ahead close to a decade ago and implemented their patient-centered medical home model and studied it very systematically. So one of the things they said, we just can't take care of so many patients per GP. We need to reduce how many patients they're caring for, given that it's overwhelming with those data I showed you about how many hours. They had longer visits. They started scheduling. These are salaried physicians. This is not a fee-for-service model. They said, yes, it's fine. We're going to actually schedule on your template time to have scheduled phone visits. More team staffing. They had a good electronic medical record. Had panel management, people who were responsible for helping with the preventive care, chronic care. So what did they find? Better continuity of care, better patient experiences, better quality, reduced ED visits, ambulatory care. Those are the preventable hospitalizations. No difference in cost, meaning that within the first year, the money they spent was just almost directly offset by savings in a one-to-one. So at least you could say it's better care, more. That's better value, right? At least it's the same amount of money, you're getting much better value care. By year 2, they actually had a net reduction in total cost. So that's a positive return on investment. And the other thing they did that was very cool is they studied the experience of the worker in these primary care clinics. So this is the control practices. This is their innovative patient-centered medical home. The green bars are at baseline. The yellow bars are at a year later. And this is what really struck me. I mean, that's amazing. So people say, you know what? It's a lot more fun to work at this practice than at these practices. Very powerful. So really getting at the quadruple aim. All right. So we've talked a lot about the medical home. I want to now kind of end by talking about this concept of the medical neighborhood. This is probably a total U.S. reference. So it did. Anybody, Mr. Rogers? Anybody? No. Okay. All right. Do you have like public television and kids shows that your kids watch and you grow up on? So Mr. Rogers was a classic kids television show from the United States. It was Mr. Rogers' Neighborhood, and he'd take kids all around to see how things work. So he has a very endearing part. I don't know, Jen was your kid. This was past your kid's time, but I don't know. You remember Mr. Rogers? Yeah, he's a beloved figure. Anyway, so the whole point is, you can have a really high-functioning medical home, but if it's in a ghetto of a health system, it's not going to actually really be ultimately what patients need. You want that medical home nested in what we'd say is a high-performing medical neighborhood, which means you want all the specialty consultant services to be integrated. You want the hospital care to be connected. You want social services to all be connected so that patients feel like this all fits together. That it's not just medical care at your medical home, but that medical home has all these linkages to everything that's going on. And I think for you, so there's two ways of doing this. One is you can be more comprehensive. So you can bring things like mental health services into your medical home. You can bring social services. You can bring physical therapy in. The other way is you can say those things are still going to be in community sites, and we can coordinate better. So that if there's good communication, there's good exchange of information. We've done that even just thinking about the relationship with consultants. How in primary care would you say there's great communication between GPs and consultants when you send a patient for referral? Yeah, it works pretty well?
Yeah, it does.
No, it does. No. So that's a trouble in the United States. We find a lot of time in the old model, a patient shows up with a referral to a consultant. The consultant isn't quite sure what they're there. They do the consultation. It doesn't get back to the primary care physician in a timely fashion. In one of the systems I work on, we did an electronic consult system where we embedded an EHR with an internet platform. So I could put a consultation request in, and the whole point was sometimes the specialist didn't even need to see the patient. The specialist could say, oh, actually, I think you should order these tests or try to adjust this medication, and then let's see if the patient does better. If not, then I'd be happy to see the patient. Now, again, this is in a salaried system where there's not a big incentive for the consultant to see it. But that's true integrated care, where it's about the expertise of the consultant, not about, I mean, the patient, that's true for the patient. You're saving the patient a visit. What the patient wants is that expertise of the consultant brought into the medical home, not necessarily a visit to the consultant. So we did this. The other thing that when patients actually then did show up with a consultant, what we found is the specialist had a much clearer idea of why the patient was there, because we had much clearer communication coming from general practice to say, these are the questions I have for you, could you please address them? And also, don't just steal the patient away forever, address them, if it's surgery, do the joint, repair or something, and then bring them back and I'll manage the problem. If it's my question for you as a cardiologist is, they have atrial fibrillation, do they need to be on a blood thinner or not? Help me answer that question, and then I can manage the rest of the care. Okay, so I'm going to close now. So that's in reflection. So it's about, in the United States, again, I think Australia has a much stronger tradition of general practice. Primary care is starting from a much more, I think, solid position in the health system. We've come a long way, but now we're on this journey of transforming the model of care. And that, I think, is something that's shared across all our systems, is how do we really do primary care, deliver a different model that's going to meet the needs of patients and communities. And so how do we construct new medical homes and then build them nested within a high-functioning medical neighborhood where all the pieces fit together. Challenging in Australia also because you have the primary care sector so separated from the hospital sector. We have state-funded hospitals and federally funded primary care. But again, that's a huge need, is to not let the separate funding mechanisms atomize things into separate segments, but to think, how do we construct integrated, well-communicating parts of the system, even when the funding is coming from different mechanisms and the incentives are different. Now, I end on my talks with referencing Michael Pollan. Anybody read Michael Pollan, The Omnivore's Dilemma in Defense of Food? Anybody ever heard? He's a prominent writer in the United States on better, healthier eating. And he has a book that I think simplified it so much. So he just said, what do you tell people in order to eat healthier diets? He said, don't go into all these details about how many calories this and how many vitamins. And he said, it's very simple. 3 things you should tell people. Eat food. What a novel concept. Eat something that grew from the ground or was raised on a farm, not something that came from a processed factory. So eat food. He's also not, says, not too much. This is a big thing. We were talking about this. The supersizing thing, has that come to Australia? I mean, the portion size. I mean, that's a lot of it is, don't get the small fries, get the big French fries. And so just eat, moderate your portions, and mostly plants. He's not a strict vegetarian or vegan, but he's just, if you have a choice of what to eat, aim for more of the plant-based products than the meat and dairy. That's pretty simple. It has saved me like 5 minutes of wasted lectures to patients in the office about eat this or eat more. I just said, hey, eat some food. I tell them, I take care of mostly low-income patients, but go to the farmer's market. Don't just go to the supermarket aisle. Just go to the farmer's market. It'll probably be cheaper than what you're buying now, and just anything you buy there will be better. Don't overdo it, and go for plant-based stuff as much as possible. And that actually patients seem to understand. So I have redone this for the transformation of primary care. So get medical care, not too much, mostly primary care. So I don't know, that may be relevant to the Australians. So thanks very much for